Good evening, everyone.
Good evening.
My name is Derickson Lawrence, and I chair the Westchester County Homeowners Coalition. That organization, in conjunction with Wartburg, are pleased to bring you this healthcare town hall this evening. Some of you are here probably for the first time, visiting this wonderful 34-acre campus. Isn't this a great venue? Let me introduce you to the CEO of the Wartburg, who will bring you some welcoming remarks. Please join me in receiving CEO David.
Tom. Evening, everyone. Thank you, and welcome to the GATS Conference Center. Again, my name is David Gentner, President and CEO, the 10th President. We've just had our 150th anniversary. So very pleased to be able to host this evening's discussion, and thankful to the Westchester County Homeowners Coalition, and its chairman, Mr. Derickson K. Lawrence, for giving us this opportunity. Wartburg is one of Mount Vernon's oldest institutions, one of the area's largest employers, and home to nearly 500 elders, some of whom have joined us here this evening. It's a sacred place where all lives matter. We are an active part of healthcare reform in this region. We are part of right-sizing, part of a move to home and community-based services, part of the plan for better population health, better care for the individual, and health care at lower cost to the taxpayers. Towards this end, we've raised 2 buildings recently. We've built 2 buildings, both LEED certified. We've downsized our long-term nursing facility beds by 30. Our Friedrichs residence is home to 61 active and vital seniors. That's a new building. And our rehab center will admit 1,500 patients this year with an average length of stay of 20 days. We've also renovated our Meadowview Assisted Living building and opened an outpatient clinic. However, we are very much an at-risk provider. We are a standalone, single-site provider, one of a few voluntary not-for-profits left in the region. So to take a step back from progress is very difficult for Wartburg. We provide services to this community's elders, to those most frail and compromised, and most of our care is sponsored or paid by Medicare or Medicaid. So most of those we provide services to are known as dual eligibles. We have, so that's 71% of everything that comes through. It's a $50 million operating budget. We have organized labor, and most of the costs are fixed. So again, to take a step back from any progress that's been made is difficult. So as a representative of Wartburg, I look for positive opportunities in any reform effort. And I believe all of us, our state and national elected representatives, providers, insurance companies, all of us have worked hard over the past few years to meet, I think, our initial reform goals, our outcome goals, and our Medicaid cap goals. But taking a step back again is daunting, and while we accept the challenges, you know, with our scale and our cost structure, you know, the idea that this campus could evolve once again as a social ministry is very real. So simply put, you know, we're a 5-star provider, you know, and everything that you can measure from an outcomes perspective, we're top tier, top quintile, and very, very proud of that. But what we won't do is put ourselves in a race to the bottom. So there's only so far we can go, really, in terms of losses. and sustainability, and so we'll just continue to kind of evolve and look for those opportunities, but we're not there yet. But the possibility is very real. And when you think back 100 years, you know, we're doing things today that they never even imagined. This was an orphanage. It was an orphan farm school, and so we've evolved quite a bit. So, but we're not there yet. But I will be the first one to throw the wet, cold blanket on the meeting tonight, Derickson, and say this is a tough time. That was a joke. I was trying to be funny. But I look forward to the presentations, discussion. I believe our Assembly member, Gary Pretlow, will be here soon. And Councilmember Edwards is with us, and thank you so much for being here.
Thank you, Mr. Gentner. Someone said recently that healthcare is complicated. So, understanding that, I think we're going to need some divine inspiration before we get started. For that, I'm going to call on Reverend Troy DeCohen to do the invocation. He is the president, newly minted president of Westchester County Black Clergy, United Black Clergy.
Thank you, Derickson, and thank you, David Gentner. Am I?
Yeah, that's good. Close enough.
It's close enough. It's better than Wartburg. Again, I thank you for the privilege and opportunity to participate. And as David mentioned, and he said it in a kind of jokingly manner, but we in tough times. And yes, we're going to need the arm of the good citizens to do what they have to do, but at the same time, we're going to need the arm of faith to do what it has to do. Well, a lot of people are in jeopardy, especially with all the healthcare reforms, as well as so many other things that are before us. So just let us pray in your own way, but I'll lead. God of heaven and earth, we pray, and we seek you for guidance, direction, for help and strength in order to mobilize us as people of good conscience and good faith to address the crisis, the things that are before us, that we could be an instrument to help the many others. We pray for this forum, that it will be informative, inspiring, and that it will lead us in the direction that we all need to go. So we thank you, we praise you, and we acknowledge you in this place, and we just ask for your blessings, and we all just say, amen. Thank you, Doug. Thank you.
Okay. Let's continue giving thanks. Right now, what I'd like to do is give thanks very quickly to those who have helped us get this forum together. The Wartburg, in particular, Karen Thomas and Angela Simonello, and our team. If I can just ask you to just come out very quickly, or stand. Can you come out? Sue? Mr. Gentner, come on out. Oh. Yes. Please, come on, come on. Okay. Without the help of the small group, we wouldn't have been able to put this on, so I wanted to express thanks to them, and the devotion is getting us off the ground, so thank you. Appreciate it. Okay. We've heard a lot of phrases over the last 6 months or so. Those that have been very popular have been resistance, fight back, don't take away my ACA. And in large measure, those have been very effective. In terms, we've seen the GOP's mantra have gone from repeal and replace for the last 7 years, and most recently we hear it repeal, repair, and replace. We've also seen that it's been somewhat effective, obviously, in what came back with the most recently announced GOP bill. And that what we're hearing is from the very right that what has come about has actually been Obama light, if you will. So that kind of approach is certainly effective, and we believe that will continue and should continue. It's what I call the third arm of government, the voice of the people. So that's effective, that should continue. The reason I raise this point is what we want to do here this evening is something in parallel to this, but somewhat different. What we hope to do is unpack the information, share this information with you, engage these panel members so that we can all be proactive rather than reactive, and at the end of the discussion, really focus on how do we go forward, and how do we go forward particularly in New York State. So the way in which we'll proceed here is we'll have 2 segments for this. The first will focus on the elephant in the room, and that's what happened. That is what happened most recently with the new GOP bill. We will begin with the first speaker, but I'm going to call Angela to come forward and just announce those panel members, and then we will go forward with that. Angela Simonello, please.
Hi, as Derickson said, I'm Angela Simonello. I'm the Vice President of Development and Marketing here. So if you think Gentner is hard to pronounce, Simonello is actually spelled with a C. So welcome to our campus. We're so happy to see you here. So as Derickson said, I'd like to welcome our panelists and our moderators. Mr. David Robinson is an investigative reporter with the Journal News. Derickson Lawrence from the Westchester County Homeowners Coalition will also be moderating tonight's event. Panel members include Dr. Dan O'Connell from Montefiore Medical Group, also part of Physicians for a National Health Program. Dr. Alan Toles, Vice President, OBGYN, Long Island Jewish Medical Center, and Mr. David Gentner, the President and CEO of Wartburg. There'll also be guest speakers, Mr. Kevin Dahill, the CEO from New York State Suburban Hospital Alliance, and Ms. Kristin Mooney, am I saying that right?
Correct.
Yes.
Mr. Mooney.
From Montefiore, Bronx, the Senior Director of Health Policy. So welcome and thank you so much for being part of our panel tonight. If you have any questions, we are passing out index cards just to keep it flowing and not repeat questions. So if you didn't get an index card and you do have a question, there are people who are passing them out. If you just want to raise your hand, those that have an index, those who are passing them out, so you know who to kind of look for. Thank you. And then we'll collect them again and get your questions up in front of the panel. Restrooms are located out these doors through the second set of doors on your right. So enjoy and thank you again for coming.
Okay. So we are ready for our first speaker. Our guest speaker, Mr. Kevin Dahill. Let me tell you just 2 sentences about Mr. Dahill. He wears a few hats right now. He presides over 2 regional associations. He's president of the Nassau Suffolk Hospital Council and also the Northern Metropolitan Hospital Association. This is the umbrella for those 2 regions are called the New York State Hospital Alliance. He is also the executive VP of the Healthcare Association of New York State. He's been in Washington for the last 2 days, actually just got off the plane today, and he's here with us. So please welcome Mr. Kevin Dahill.
I'm going to do this from out here. Hopefully everybody can hear me. My family's told me for years I got a big mouth. Some slides. I don't read slides. I just look at them to remind me what I wanted to talk to you about. So what I want to talk to you about tonight is, as Derickson said, I currently represent 51 hospitals in those two regions, Long Island and in the Hudson Valley over here. I've been doing that for 15 years. I'm also a recovering hospital CEO. I ran New York United Hospital in Worcester for 6.5 years, and before that I was an executive at Columbia Presbyterian in Manhattan for 25 years. So I've been in this business for a long time, and have seen a lot. Not quite what I'm seeing today. I haven't seen that before, but I have seen a lot. So I want to try to, in short order, explain to you basically how economics work in the healthcare system, particularly from the hospital's vantage point. Okay, so you have a little bit of a foundation. Then I will get into the ACA. Oh, you are, okay. I will get into the ACA, the Affordable Care Act, what some people coined Obamacare. He didn't object to it, so you know, I'm not going to get crazy about it, but I like to refer to it as its formal name, the Affordable Care Act, which is what it was meant to be, an Affordable Care Act. So I'll talk a little bit about that, remind us all what the purpose of it was, what the intent was, what happened in these past several years with that statute in place. And then I'll take you through very up-to-date what is going on today in Washington, new bills being drafted and so on. And I've been very involved for the last couple of days down there, so I can get you quite up-to-date. What I would like to ask is don't shoot the messenger. I'm here. I'm going to try to convey to you what the facts are. Give you some numbers, so you just kind of have, there's not going to be a quiz, but just so you have an idea of what the facts are, so you can make your own conclusions. I will share with you where we as the hospital industry in New York stand when I get into the discussions about what's happening now. So if we could. So the history of hospitals is interesting. Sometimes what I start off was put a big blue H up and say to audiences, what is that? And everybody says, well, that's the sign on the road for the hospital. But you know, the history of hospitals, when they were first founded in the beginning of the late 19th century, 20th century, they were the places in the community where people go to when they're sick. And a lot of them were set up, like the Wartburg, with religious backgrounds, with institutions that wanted to create that kind of a community asset. Over the years, for a variety of reasons, hospitals have spread their wings into certainly staying and being a place where you go to if you're sick or injured, but where you also go to if you're going to have a baby. Also to a variety of clinics, specialty and primary care clinics, because there was a need identified in that community. So the hospitals have expanded, and many of them have taken on other goals, teaching and research. Those institutions that we call academic medical centers. Kristin is from Montefiore. Dr. Toles is from North Shore LIJ. Those institutions have as goals patient care, teaching, and research. So the hospitals have expanded their horizons over the years. And that's an important thing to remember, please. Today, because a lot of sanity has been injected into the healthcare system, in my opinion, we have been trying to address some of the absurdity that has existed in healthcare economics for a number of years. We've all worked through a reimbursement system that has rewarded volume over value. What do I mean by that? I mean that the way in which the payment structures were established for years were the more we do to patients rather than the more we do for patients, the better we get paid. When I was a hospital CEO, my chief financial officer every month was curious as to how many surgeries we did that month, how many tracheotomies we placed in people's throats. Why? Because the reimbursement for those kinds of things is higher than if we're treating an asthmatic patient or a patient with simple pneumonia. So the system really has had a tradition of really rather absurd economics. We have been trying with our partners in the community to try to create a new paradigm where we say, we still want to be that place where people come to when they're sick, but if we can prevent them from becoming sick or too sick, that should be our goal. We should be trying to put more care coordination in place, more primary care. We should really be trying to look at this in a whole different way. And there have been a number of ways in which we have shown that we've been successful. We've got a long way to go, a long way to go. But we've got institutions represented right up here on this at this table that are working very hard to try to accomplish that. So I like to call it that hospitals are becoming hospitals without walls, because we got to break down some of these traditions and work more closely with our partners in the community, community-based organizations and so on. And we've been doing that. Please. This I'll just throw up there. And everyone wants to get, when you talk to people intellectually about health care, all they want to talk about is what can you do to bring down health care costs, right? And it's a very good question. The problem we have, the challenges we have are just listed there. Technology is increasing, improving, some would say. Specialty care is available. In my over 40 years in this business, I have never seen anyone who's brought their mother or father into an emergency room and said, wait a minute, before you get that MRI, how much is that going to cost? So we all want healthcare costs to come down until we get sick or somebody in our family gets sick, and then we want everything. And we expect everything, right? So these drivers are what has been challenging us. Thanks. Now, here's basic financial economics that you need to have a basic understanding of before we get into what's happening. How do hospitals get paid? And this is true for doctors for the most part as well. And I'm generalizing here, but on average, the hospitals I represent get paid 50% by the government through Medicare and Medicaid, and 50% through the commercial marketplace, commercial insurance companies. Now that's an average. We have hospitals, rural hospitals way up in New York State, that are getting paid 80% by the government and 20% by private insurance. But in general, in this region, it's about a 50-50 split. And the way it works is that on the commercial insurance side, there's a negotiation. So healthcare in this country has been transactional. What do I mean by that? What I mean by that is that a hospital or a hospital system sits down with an insurer and negotiates price. And the reason why you've seen consolidation of hospitals is because the bigger they can get, the more of a critical mass they can represent, the better deal they can drive for themselves. Why is that important to them? And it sounds crass and businesslike. Well, on the government side, Medicaid does not pay costs for services. So hospitals, on average, get about 80 cents, 85 cents on the dollar for the care of Medicaid patients. Medicare is a little bit better. It's about 95 cents. So you got to make that up somewhere. So they seek to make that up in the prices that they negotiate with the commercial insurers. And that's the way it's been working here in New York State for several years. Okay? Now let's talk about the Affordable Care Act. And let me begin by saying that when the final bill was negotiated for the Affordable Care Act, we came out in support of it. And we contributed money to it. And I'll explain what I mean. Why did we come out and support it? Well, we were lamenting for years, the hospitals were, that when patients would arrive in our emergency room, for conditions they probably should have been seen in a doctor's office and maybe could have been prevented, and didn't have coverage, we had to take care of them. And there's a federal law that says anybody that walks into any emergency room has to be treated and stabilized, regardless of their ability to pay. That's fine. That's the moral and ethical thing to do. But we were lamenting for years that we had a sizable number of people that were coming into the emergency rooms that couldn't pay. And we took care of them. So now comes along a new initiative out of the government that says, we want to place on the books a law that is going to seek, and I have some of the goals down here, but it's going to seek to address this issue and provide more affordable insurance to people who heretofore could not pay for it themselves. How could we have said no to that after all those years of complaining about people being uninsured? We couldn't, quite frankly, and we didn't in the end. There was some difficulty and there was some bumps in the road along the way in how that bill finally got negotiated, but in the end, we couldn't. Now, when they pass a bill like the Affordable Care Act, and the one now that they're entertaining in Washington, they've got to identify how they're going to pay for it. They've got to, you know, put the dollar figures to what's going to happen here. So when the Affordable Care Act was put in place, the goal was to provide in states that wanted to do it a mechanism to expand Medicaid coverage in those states. The second thing they wanted to do was provide subsidies to people who wouldn't qualify for Medicaid but couldn't afford a full health insurance policy themselves. So provide some assistance so that the family would pay some and the government would provide a subsidy. That had to be paid for. So how was it paid for? Well, the insurers, the device makers, and the pharmaceutical industry were all taxed because they are for-profit industries. So they got a tax put on them. But again, remember the goal was to get people covered. Hospitals, who are not-for-profit institutions, were receiving a special reimbursement we called it disproportionate share. You don't have to worry about the title, but it was, we were getting some monies in exchange for the fact that we were treating so many uninsured people. It was added to our reimbursement. Government said to us, if we're going to now cover those people, you don't need that money. But we need it now. We need it up front so that we can justify the expense and get this law passed. So we agreed to take that extra reimbursement, cut it, and make it a down payment, assuming people were going to get coverage, which they ended up getting. So that was the goal. There was some technicalities in there and so on that we can get into in the questions and answers. But as I said earlier, how could we say no? Now, let me talk about what happened in New York State. I want to keep it about the federal government and the Affordable Care Act. But what happened in New York State? So every state, once the ACA was passed, every state in the country had the ability to create their own insurance exchange and to expand Medicaid. Now, here's some important things to realize. New York State has always, as far as I can remember, has had the most generous Medicaid program in the country. Generous in a couple of ways. We provide a Medicaid beneficiary the whole array of health benefits. So obviously medical benefits, mental health, podiatry, dentistry, all of it. We also have been very generous in our eligibility standards. So when the ACA was passed, we were already at a point where we were putting people on Medicaid in New York State who were up to the 133% of the federal poverty level. And the thing you should know is that a lot of other states in this country were not that generous with their Medicaid programs. Their eligibility standards, some of the states were at 100% of the federal poverty level. And the coverage didn't provide anywhere near that array of benefits. It was almost like catastrophic coverage. So the ACA wanted to identify those states that wanted to do Medicaid expansion, but there was a catch. The catch was you got to come up to 133% of the federal poverty level, and we want there to be a reasonableness to the benefits that you offer, in exchange for which the federal government would provide those states with some extra federal dollars. Okay? Medicaid is a shared expense between the federal government and the state government. So, and it's on average about 50-50. So the state pays 50% of the bill, and the federal government pays 50% of the bill. But you can see now, in fairness, to those that are at the federal level, if you have a state like New York that has a very generous program, it's going to cost the federal government more, right? Nevertheless, they wanted to standardize it across the whole country, and that was the goal. 31 states said, we're in. We'll expand Medicaid. We'll take the deal. And the rest did not. I would submit to you that those were political decisions that were made. Be that as it may, that's what it was. The federal government said, if you state don't expand Medicaid, don't create your own exchanges, we'll come in and do it. But for states that want to do it themselves, go at it, and we will provide you with the extra financing. We in New York were one of those states. We said, we'll do it. We didn't have to raise our eligibility standards. We were already there. Nevertheless, it's interesting. You will hear nationally 20 million people got coverage through the ACA. That's an accurate number. But here, and I'm staying with this for a minute, in New York State, about 3 million people got coverage since the ACA was passed. About 2.4 million of those qualified for Medicaid, additional people on Medicaid. The rest got insurance plans through the exchange, okay? And that's how it breaks out. The Medicaid, you can see the Medicaid. So these were people who could have qualified for Medicaid before, but came forward when the ACA got passed, probably because they heard about the ACA, and came forth and they qualified. The others qualified for subsidies. And I'll tell you why that was important in a minute. Now, please. So, obviously, we've had a national election. We've had a change in political majorities at the federal level, and this whole thing is getting revisited. And as Derickson had said, you've heard the terminology, repeal, replace, repair. This was one of the hallmark campaign promises that the president and the new leadership in the Congress ran on. So they have been anxious early on in this new Congress year to put something out there. And they have done that. So let me describe for you where we're at right now. Believe it or not, I don't know if you're aware of this, the federal government never adopted a budget last year. And that's, again, because of the politics that existed last year. Different set of dynamics, but they kept the country running through what we call continuing resolutions, meaning every quarter they just said whatever we spent last year, the last quarter we'll spend it again. They never passed the budget. I don't know about you, but in my business, and I would suggest a lot of your businesses, you couldn't possibly function that way. But the federal government did and can. That's why what's available to them is this thing we call a reconciliation process. They now have an opportunity to pass a couple of reconciliation bills that are left over from last year. Now, why that's important is for two reasons. They have to do it as a budgetary maneuver. And that means that they can't accomplish everything they want to accomplish in the first phase of this bill, They have to wait and go to a second phase. So this first bill that they are currently negotiating can only deal with the financial issues that were attached to the Affordable Care Act that they want to repeal. Okay? They have to be budgetary in nature, not policy. So, what does this bill that they have brought out do? This bill, and it's changed as of a couple hours ago today in a number of ways, but this bill repeals certain aspects of the Affordable Care Act. There were two mandates. There was an individual mandate and an employer mandate. The individual mandate was any of us that are a citizen in this country would be required to have health care coverage. And if we didn't have it and couldn't demonstrate that we have it when we do our annual income taxes, we pay a fine. We could talk about that when we get into the Q&A, why that was in there and why it didn't work. The other thing that they repeal is the employer mandate, which requires employers to provide coverage to those that work for them, or they get a penalty. They've taken that away. Remember all those taxes I mentioned? The device makers, the insurance companies, and pharmaceuticals, all those get repealed. Very happy people, those groups. Remember the cuts I said we agreed to? They don't get repealed. In expansion states, they do get repealed in non-expansion states. Keep in mind what I said earlier. Those non-expansion states made those decisions for political reasons. And now they're actually getting, in my view, rewarded for not having done Medicaid expansion. So, where are we? Well, there was a lot of frustration because until we got to Monday night, actually, of this past week, nobody saw a bill. We knew there was maneuvering going on. What happened in January was the two committees of jurisdiction in the House of Representatives, Ways and Means and House Energy and Commerce, passed resolutions that basically directed it themselves to come up with a bill. That's all that happened there. Not David, but some people in the media got that a little confused. They thought those resolutions back in January were the actual bills. They weren't. They were actually place setters, just directing themselves to get to work to do this. The bill that came out Monday night is similar in nature to several bills that the Republicans tried to pass during the time of the Obama administration that a couple times didn't pass and a couple times he vetoed. And that's the bill that everybody's got themselves worked up about right now. The two committees, Ways and Means and House Energy and Commerce, do what we call markups of that bill. They take the bill and they theoretically listen to all of the constituents that come in and talk about it, and they make changes, change wording, and so on. The Ways and Means Committee completed that process at 3 o'clock in the morning last night. House Energy and Commerce Committee is still going at it. And the problem they're having politically is fascinating to me. They released the bill finally Monday night, and lo and behold, this whole group of 33 Freedom Caucus members in the House, who tend to be ultrally conservative, fiscally conservative, who hadn't seen the bill before apparently, come out with all kinds of objections to it, thinking that it's too forgiving. I think somebody did call it Obama light, but that they felt it was too forgiving and contained too many entitlements. You've got others in the Republican caucus who are getting frightened now because they're hearing from folks like us that this has got a lot of problems attached to it. And so there's a lot of stirring going on down there. Nevertheless, the leadership, as of today, is saying they want to get it to a vote in the House of Representatives by March 23rd, just the week after next, so that they can give it to the Senate to vote on before their Easter recess. I'm a little skeptical at this point, given all of the dissension that exists, whether or not they can do it. But that's where the politics are at now. So as Derickson mentioned, I was down, brought a bunch of hospital CEOs down yesterday and today, and we visited with all of the Republican members of the delegation. We didn't have to go see your boy. We know where he is. So, but we visited with all the Republican members. We have 9 members of the delegation in New York are Republican. We hit every one of them to talk to them about the issues. And so let me just describe in general what they're proposing here, so you know what it is, and then you know why we're concerned about it. So if you could. So, as I said, the Affordable Care Act called for, let's start with the commercial side, the exchange side, provided subsidies to people who could purchase insurance at various price points that they wanted to purchase it at, and they would get, a lot of them got subsidies to help them purchase that. What this bill would do would be to repeal the subsidies, not provide cash subsidies, but provide refundable tax credits, okay? Meaning that you would get some assistance, but it would come later in the process, like when you do your income taxes. Now, the problem with that is over in our Long Island office at our hospital council, we are a state-funded navigator agency. We have enrollers that go out and enroll people in these plans and in Medicaid. So we get to meet these families. These are families that are earning maybe $50,000, $55,000, have 2 or 3 kids, trying to maintain a household. And quite frankly, if they don't get that subsidy as opposed to a tax credit, the tax credit doesn't help them, you know, manage their budget for the next couple of weeks before they get paid again. So this business of moving it over to a tax credit is troublesome. And that's when you hear us talking about people could lose their coverage. That's what that's about in that grouping. Then you go over to the Medicaid side. There's a couple of things happening there. The first is they do say that for the states that expanded, we will continue to cover those folks until the beginning of the year 2020. So they try to say, you got 2 years, you know, what are you worried about? Anything could happen in 2 years. So they will continue to provide the coverage, and they will continue, remember I said they pay 50-50 on Medicaid, that's in general. For the Medicaid expansion beneficiaries, federal government pays 90% of the cost, and the state pays 10%. They will continue to do that in this bill until 2020, January 1st, 2020. Then the door locks, and if the state decides they want to continue to enroll people in Medicaid, it's on the state. The second thing, and this is the most troublesome thing for us in New York, if this was to happen, they propose, you can call it what you want, a block grant, they call it a per capita cap. It's a block grant. But what it is they say as of January 1st, 2020, we, the federal government, will no longer be on the hook for any increases in your Medicaid spending. We're passing the risk to you, the state. So, and we're going to take whatever it is we were paying you in 2016, whatever that amount was, and that's what we're going to give you going forward. 2020 on. And if you can't keep your costs down as a state, it's on you, New York, and every other state. So, because of what I said about New York, and how, and I should have mentioned this earlier, 30% of the people who live in New York today are on Medicaid. 24% of those people are the young folks. 70% of the folks that are on Medicaid are the sick and aged. You know, 90% of folks living in our skilled nursing facility, you heard David say, a majority of his patients are dual eligible, Medicare and Medicaid. So this population's not going away. and we have others that are aging in place. So for us to be thinking about the effect on New York's economy, I spoke to a group of commercial real estate brokers in New York City a couple of weeks ago. And one of them got up and said, why should I care? You know, I don't have anybody in my family on Medicaid or anything. I said, I'll tell you why you should care. If you either live in New York or you do business in New York and you pay taxes in New York, get ready for those taxes to go up under this proposal. Because New York is not going to renege on the promises they've made to their Medicaid patients. They're not going to, you know, drive benefits down. They're not even going to drive eligibility down. 30% of the population is enrolled in Medicaid in this state. It's 33% of the state's budget is its Medicaid budget. So that's why this is a big problem for the New York State and the New York State economy. So when we visit with Republican members of Congress from upstate, many of whom have drank the Kool-Aid and think that, you know, we can do this. We say to them, you know, I'm from downstate. You folks have got a bigger problem in terms of the lack of manufacturing, the lack of, your major employers up there are the hospitals. And you're going to have a big problem on your hands when this hits, if it does. So we can keep going. I want to, New York State takes a big hit. I thought that was clever, the little punch in them. We can keep going.
They're very quick, I promise.
Sure.
This is for just New York State, correct?
I don't know what you're holding.
It's universal.
Yeah, I think that's another group speaking. Yep.
Oh, it's another group. So
Yep.
you can't answer a question.
No, you'd have to be around for that discussion.
Okay.
Yeah.
And the other thing was when you were talking a few minutes ago about the subsidy and the people getting paid and they had to wait for the next paycheck or something. You're saying the subsidy that they apply to each monthly premium, correct?
Yes.
I thought that could be applied every month. You either took a tax credit and you got it back at tax time, or you could apply it every month.
Right, but in this case, in this proposal, that's not available to you.
Oh, that's what you mean.
Yes. Thanks.
Is there a person here I could grab outside on this question on the universal?
We can keep going.
Sorry. Thank you.
That's all right. That's all right. So here's the numbers for New York State. And this just has to do with the Medicaid expansion, not the block grant that I'm talking about. And this is coming from the governor and his staff, not just from us. This could cost the state of New York $3 billion on the Medicaid expansion, $1 billion on the exchange, and another $250 million, which is throwaway money when you're looking at these other figures, on the rest. That's going to hit the New York State economy if this thing happens. And that's the point that we're trying to drive home with our members of the Republican conference in New York. So the politics, you know, I don't know. I think that the leadership is so concerned that they're getting so much pushback from the Freedom Caucus. I hope this doesn't happen, because this could get worse. When I was leaving, just today, I heard somebody say they may not go to 2020. They might go to 2018, which, you know, would be like smacking our face right in front of us if that was to happen. I hope to heavens that doesn't happen. We're trying to fight the 2020, but beware. I'm not even going to burden you with those numbers, but that's how they break out. The repeal is the white part. The Medicaid expansion is the darker part, but that's where we get those numbers and how it could affect New York. Okay. And that's the governor's quote as to why this is such a big deal. Okay. And here are some other just interesting statistics. When you talk about Medicare and Medicaid, you know, if we're not there yet, if we're not on Medicare, or we've not had a situation where we've got a member of our family on Medicaid, but look at how it affects our populations and our economy. I mean, 81 million Americans covered by Medicaid. So 25% of the country is covered by Medicaid. As I said, 30% in New York State. As I told you about the 70%, we've been very generous, so we've had significant growth here in New York. And that speaks, quite frankly, also to the economic conditions in the state. I kid you not, as much as we may have concerns day to day about what we're up against here, you go up into the northern parts of this state, and it's scary as to the economy. We've got hospitals that, have 5 days of cash on hand that we're awfully worried about whether they're going to survive. Forget about 2020, like in the next year. So we got a lot. These are very serious issues. Yes, sir. And don't forget that your hospitals, the healthcare enterprise is a big part of the economy. We are one of the largest employers in many of the zip codes in which we reside. If hospitals have to start laying off people as a result of this, that's going to affect your local economies, and that's another aspect to this. So I think I've given you, I hope, a foundation here, Derickson, and I'm going to be up on the panel for questions, and look forward to hearing your questions. Thanks.
Thank you, Mr. Dahill. We're going to swing to the panel members to respond to some of what they heard relative to the Medicaid expansion part of it. And so I'm going to go to Mr. Gentner first, and we'll work our way coming this side. Mr. Gentner, share with the audience, number one, why did you feel it was important to participate in this forum? But the B part of this is, considering some of what you heard from Mr. Dahill's presentation as it relates to Medicaid expansion and the rollbacks, how is that going to impact your local institution as one of the larger employers here?
Okay, yeah. So, so I guess maybe working backwards from the expansion issue, the expansion issue is really not an issue that will impact Wartburg. Our those we care for who are sponsored by Medicaid, they would have already been part of the Medicaid enrollment system. They would have been Medicaid eligible. They're, as I said, very frail, very compromised, medically indigent, and the elders in our community, right? And so, and we really pride ourselves on caring for people who have nothing, and so the fact that they're eligible for Medicaid, and Medicaid does pay for some of the cost of their care has always been there, and will still be. Our issue is when you move to a block grant system, it will affect the rates. So it's not just the eligibility; it's going to be the rates. So it's very easy for these are big numbers, but big numbers can have an even a bigger impact on a smaller organization like Wartburg. So you can shave off 1 or 2% of Medicaid nursing home rates, and it has a real impact on the state budget. But when that trickles down to a nursing home like Wartburg's, it really becomes unsustainable. So for me, it's more of a concern about the rates that are inadequate already. We lose. So our costs exceed reimbursement for every Medicaid day by more than $150 a day. So that's a reference point for you, okay? So it's the rates that I'm concerned about, not so much the eligibility. Our employees are in the main $11.99 employees, so they have good health plans, and to stay competitive, yes, we're one of the largest employers. It's not really conceivable to me to think that we wouldn't still find a way to offer some kind of health benefits, but I certainly don't like the idea that we would shrink any more in size, because we employ 600 people here, and that is a big number for the city of Mount Vernon. The first question, it's while we're really trying to evolve and balance our portfolio, we do everything we can to be a good post-acute partner to our hospital systems. We're still a standalone. We have no formal sort of relationship and affiliation. So 70% of our revenues are Medicare, Medicaid, and that's a big number. It should be the smallest number in our as we look at revenues across the continuum, and it's not. And so while we're looking to balance with other types of payers, we're just not there yet. And so we've really worked hard to turn this organization and get to a balance, and to think that we can step back is just really very, very, very difficult.
Thank you. I'm going to just switch the questions around to Ms. Mooney and then to Mr. Toles. It's the same question, but choose anything that you heard from Mr. Dahill's presentation and respond to what are you most concerned about what you've heard in terms of the new bill and its implication on your facility.
Please. Hi. So Medicaid, number one, that's our number one concern. I think the most recent estimates say that about $4.5 billion will leave the state of New York by 2021. That's significant. What happens to Medicaid in a scenario where federal funding is no longer there to support this entitlement program? As you said, do rates get cut? Does enrollment get cut? Do benefits get cut? What happens to patients in that scenario? If you're not getting things like preventive care, you're only getting emergency care. So I really think patient impact is something that I don't want to get lost in this conversation. It's very much a financial conversation. Often it's a hospital economics conversation, but I really want us to focus on what happens to our communities in this scenario when Medicaid is constrained.
I would say that I'm not so much concerned about how it's going to affect our institution. I work with the Northwell Health System, which is one of the larger employers in the metropolitan area, over 61,000 employees. Very savvy CEO, Michael Dowling, who has worked in and around and through the healthcare system for years and has the health system on pretty sound footing. I think more importantly is how it affects you. People who are the working class people, or people who have benefited from what this country should have long had years ago, affordable health care for all of their citizens. And this was signature legislation through President Obama for the last 8 years, and now they're talking about taking it away. And what that does is, if you can't have affordable health care where you can pay for it with subsidies for your family, or if you're on Medicaid, or if you have family members on Medicare where the government is now no longer providing these subsidies, what happens? Now you can't go to the doctor because you don't have an insurance plan that your doctor takes. Now you don't get preventive health care. Now you have to wait until you're really sick, and then you show up in the emergency room. The hospital won't turn you away, but now you've got a problem that could have been prevented or have been reduced several months or years back. This is the concern, and this affects my community. disproportionately, and the health disparities amongst brown and black people are going to be much greater and affect us much greater. So that's my concern, is how is it going to affect you? And you know, it's unfortunate that here we are in 2017, but we've got another 3.5 years before the next election. And had we voted as we did 4 years ago, we probably wouldn't be having this discussion. But I'm not so much worried about how it affects my health system. I'm more concerned with how it's going to affect the people in my community, and consequently showing up with more severe illnesses, greater heart disease, greater cancer, greater deaths. And for the richest country in the world to have a system of have and have-nots is just, in my estimation, unconscionable as a physician. We will continue to work through this as best we can, but I think we'll probably want to hear more from the audience about your concerns and how you can best manage these next several years, where slowly but surely what has been worked on for so many years over the last at least 8 years to try to get you to a point where now you can have health coverage for everyone is probably not going to be available.
Before we head over to the audience questions, just a couple points that I think didn't really get fleshed out in the discussion was what happens, especially for the market here. A lot of the reporting I do is on a lot of the consolidation that was touched on, and there's two representatives of health systems here that had expanded their reach into the market here, Northwell and Montefiore, both being part of that push northward. What does the proposal mean for all this consolidation and investment that was made as part of the Affordable Care Act? What does that mean for patients when their community hospital is now under the umbrella of a large health system that wasn't necessarily in their community 6 years ago?
So I think, can you hear me? Okay. So I think that large size helps in this scenario, right? You get economies of scale. You can do things like negotiate better. You can lower your overhead for a small community hospital. It's really hard for a small community hospital to do everything, right? To be the hospital, to do all of the administrative things that need to be done. And I think that larger size also helps with value-based payments and population health. And I think that is something with bipartisan support. So that's hopefully something that stays the course through ACA repeal, should it happen.
Is your reading of the numbers that they're out there? I mean, is there concern that, some of those incentives that were there to make those investments under the Affordable Care Act, that they're going to continue? I mean, will community hospitals be closing nationally, and not necessarily locally, but nationally? I mean, that seems to be the safety net hospital being the most at risk in these new worlds.
Let me take a shot at this.
Sure.
The Affordable Care Act did provide funding for a new division in the Office of Health and Human Services called the Office of Medical Innovation. And that office provided grants to a number of health systems who wanted to pursue a new, more rational reimbursement methodology. Remember, I was talking about the absurdity of the volume-based system. We're fearful, it's not in the bill. Again, this wouldn't be a reconciliation issue, but we are fearful, maybe apprehensive is a better word, we're apprehensive that the Secretary of Health and Human Services, just by way of regulation, could just terminate that office. And some of the programs that are in place would stay in place, but the ability to put new ones in place would be severely curtailed. We're very apprehensive about that.
Oh.
So let's turn our questions now to the audience.
Effects would the GOP plan have on Medicare? Specifically, will the donut hole in prescription drug coverage still be phased out by 2020?
They haven't put anything in this bill related to that. We'd be watching for something. There's two schools of thought. One is that the they wouldn't be crazy enough on the heels of this in the next year to go after Medicare as well, prior to the midterm elections that would come up in 2 years. So right now, nothing has happened, but you should be aware that there's a big push to revisit a lot of regulations that are in place, and that would be something we'd be watching. But politically, I can't, given the trouble they're having just on this, I can't see them trying to go after Medicare, at least in this year or the next.
Make a quick comment, Dan O'Connell from Montefiore Family Doc. I actually spent about an hour or so searching this donut hole question, and I looked all over the internet, and there's been zero commentary on this, because closing the donut hole, right, which when seniors hit $3,500 or so in pharma costs, basically you no longer have coverage until you hit a catastrophic amount around $8,000, and that's closed between 2014 and 2020 under Obamacare, so it's being phased out. And if Obamacare is repealed, that means the donut hole is back, but we don't know the details in the bill. No one's commented one way or the other, and they certainly don't have the bill. By the way, we are closing the donut hole, and they haven't said they're not. So I just think that nobody's really asked this question about the bill, and we probably have to wait for the details. But it's a huge question, because it would be the first attack on Medicare, and we'd find out what happens if they try to attack Medicare.
Yeah. There's one other question. It says Representative Paul Ryan was talking on television today again about state high-risk pools. My understanding of the GOP plan is that there still will be an individual marketplace that would not charge different, that is higher premiums based on health risks, so that high-risk pools should not be necessary if premiums are affordable. Is he A, mistakenly citing his own previously written bill, or B, recognizing that premiums will skyrocket without any young, healthy people signing up, now that there is no individual mandate, employer mandate, or C, does he have something more devious in mind?
Who wrote that question?
So it's correct, there's no individual mandate in the new GOP plan. What they do instead, as an attempt to stabilize the market and give people an incentive to purchase coverage in the individual market, is if you go without coverage for more than 63 days, your premiums would increase 30% for the year. So, the individual mandate gave you a financial incentive to purchase coverage, and this does the same without putting that mandate sticker on it. And the attempt there is to make sure that young, healthy people are in the individual market, again, to spread risk and make sure that premiums are lower.
And that's what didn't happen under the Affordable Care Act. If there was one criticism that I would offer in the 8 years we had the Affordable Care Act was, the individual mandate was put in place because the intention was to continue to transact health care through an insurance vehicle. Whether you agree with that as a theory or not, it was the reality, was we were going to continue to offer insurance coverage through these exchanges. To do that, the individual mandate was an opportunity to broaden this risk pool and spread that risk, and it didn't work because the penalties were too low, and they didn't get the sign-ups that they thought they would get for it. So that would have been something that we would have suggested needed to be changed, regardless of the outcome of the election, quite frankly.
My question was, why is he once again talking about reverting to state high-risk pools if he's not getting rid of the idea that sick people should still be able to purchase insurance at the same rate, at the same premium cost as healthy people? I understand the premium cost will vary depending on age, family status, and
income.
A little bit of income. You'll get a better tax credit if you're.
So they have a hypothesis that they can create a marketplace that will allow for price competition, so much so that you don't need the individual mandate. And what they're offering to do to soften the blow, and it's really an offering to the insurers, is create these somewhat federally financed high-risk pools. A lot of states don't have them. We have them in New York, but a lot of states don't have it. And well, we kind of adopted the one. We still do, but so that's what he's talking about. Is saying we'll provide some financing to a pool of patients or enrollees who've got medical issues, and that will help to create this price competition. That's their hypothesis.
Just one question that I hear a lot from reporting is this touches on it, is the pre-existing condition issue. We didn't really, I saw it on the slide, but didn't really touch on that. Where does that come into the discussion here? That's what I hear a lot of people saying. One of the biggest concerns that they had was losing the ability for someone who has cancer or pre-existing high-cost illness, what this is going to do to them and how they benefited under the Affordable Care Act.
So pre-existing conditions is one of those things that can't be repealed through reconciliation, right? If you're following the presentation, it doesn't have a budgetary impact to the federal government, so it can't be used with the method that they want to use to pass ACA repeal, so that's going to stay in.
But economically, is that realistic based on
It's a great question. It's a great question. It's hard to know how that models, right, what that effect really is in the individual market. I think it'll be helpful once we have the Congressional Budget Office present their analysis of what the legislation would do both from a coverage and spending perspective. I think that'll help us start to think about the quantification of that.
Okay, I have a question over here.
Okay.
Hi, I'm Tom Dargan from out of left field. I live in New Rochelle. I have a friend right here in the Meadowview. My son came down with diabetes. He called me from the emergency room. He's 25 years old, so I'm kind of still in charge here. Asked me to get him some metformin. And I shopped around, and I found out I could pay up and down Main Street in New Rochelle, probably the same in Mount Vernon, $321.94 or $14, depending on where I just popped in. Then I got, New York State requires drugstores to post their price lists. So I looked at the 10 top drug costs. If you walk up and down Main Street and you don't have insurance, or you're still in your deductible, which many young people are, and poor people, Abilify is $2,800 at Walgreens and $177.32 at Costco. What else have I got here? And for $310 you can buy Lexapro, which is for anxiety, I think, or you can buy it for $11.36 at Costco. Costco isn't always good. Sometimes Canada Drugs is better. You can get Venotin for $47.97 or $11.73. I talked to my
Is your concern the difference in drug prices as far as...
These are list prices at these drugstores.
Sure, and so your concern is I guess the question for the panel is based on the difference...
I'll tell you what my question to the panel is. My state senator, George Latimer, said if gas stations pulled this, the state would shut them down. This kind of whipsawing is horrible and unethical. You can trust your pharmacist, maybe for the ingredients, but certainly not with your wallet. And I propose to get together some folks to go to these pharmacies and leaflet them. Because I talked to my state senator, and he thought it was a terrible thing, but didn't do anything. And I wrote to the Attorney General, and I didn't get a response. So I think the only thing to do is to go out and leaflet drugstores. And I propose that folks here come with me and leaflet drugstores. And if you'd like to do that,
okay,
you can sign up.
Okay, thank you.
Well, thank you. I don't think so.
I appreciate that sort of anecdotal story with the idea of shopping and seeing the disparate in numbers. I'm going to ask you to hold that question, the answers to that question for a moment, because it points to what can we do locally to kind of address that. It also points to two things. One is that I think you want me to speak into the mic, okay? One is that Mr. Dahill talked about costs being shifted to the states. Also in this bill, there's the notion that the state will also have additional leeway and rights. So considering that, I would like to shift to segment 2 of the presentation and ask that Mr. Dan O'Connell really run through some of the slides, but focus on the key elements, because in the interest of time, what I want to do is come back to the issue of prescription drugs, because the ACA did not address that directly, and neither does this current bill. So it's important for us to look at that in the context of the question that was just raised. So if you can get started on yours, and I don't know if we need to dim the lights and maybe turn this around so that the panel members can see? Okay. Thank you.
Now, I'm not going to talk too much about the current ACA and the current repeal and replace, other than I think your point about the folks who want the tax cut, which is pharma and the insurance company. Who wants this bill? They want the bill. It's also important to know also high-income earners, folks who make more than $250,000. There's about a 1% Medicare tax on them, and also on investment income for folks who make more than $250,000, a 4% tax. And if you look at the main effect of this bill, and it hasn't really been reported this way in the media, what this bill really does is it's a huge tax cut for folks who make a lot of money, and pharma and the insurance industry, and how does it pay for that huge tax cut? By massively slashing Medicaid over time. And as you say, when this time bomb comes, when 85 cents on the dollar is paid by Medicaid, what will happen in 2021 when New York State has to say, well, who do we cut off from Medicaid? Do we cut off the disabled and do we pay less to hospitals? Is it the seniors? Is it the pregnant women who need Medicaid? And that's really, I think what's underplayed in this bill is what happens when states have to cut Medicaid. So I just wanted to mention that, but thank you for your comments. I wanted to talk a little bit about the single payer reform for this. I just want to hit a couple of other aspects, not just of the ACA and the repeal and replace, but the U.S. healthcare system as it stands. If you can go to the next slide here. And if you can go to the next one, we have our big crazy healthcare system here where, sorry if I'm blocking this here, where obviously we have the human being and they're looking to have a relationship with their doctor, but they first have a relationship with their insurance company, or they have Medicare and Medicaid, which have a relationship with the insurance company, and there's all these sort of crazy things here. And of course, as a doctor, one of the things we're interested in is getting rid of the wallet biopsy. Right, the wallet biopsies when you walk in the door. Let's see your insurance card. Oh, you have this insurance. We don't take that one. Oh, you have Medicaid. You know, this is not such a good pair. Oh, you have Aetna. We love Aetna. Oh, you have United. We don't like. So anyway, we're interested in getting rid of the wallet biopsy and treat patients as patients and not worry about what's the insurance. I work at a community health center, so mostly I'm able to do that. But then when I have to send people to specialists or from tests, a lot of times it matters a lot what the insurance is. If you can go to the next slide. And this is just keeping in mind that, as you said, so many folks get Medicare or Medicaid in New York. This is about half of folks get insurance through their job, and about a third of people get money through either Medicare or Medicaid. And when we hear all this stuff about the ACA and the 22% death spiral, that's the 3% of the population who got stuff through ACA. A lot of the discussion of the bill is basically the change that they've made about this expansion, which is important, but I think the effects on the rest of the healthcare system, and especially Medicaid, is really the big aspect here. The next slide. premiums. So in the when you have to pay for health insurance for someone, and as employers, this is an enormous thing, that it costs $18,000 now for a health insurance policy. Currently, employers pay an average in, is this New York or nationwide? I'm not sure if it's New York or nationwide, an average of $5,000 that the individual pays, right, $100 a week out of the paycheck, and then about $12,000 that the employers pay. And if you think about trying to insure folks making $15, $20 an hour and trying to cover health insurance with that, that's a lot of where the problem comes from with all this. You go to the next slide. And a lot of that's the movement toward high deductible plans, and high deductible plans is a real bane for young folks. If you don't really have a medical problem, and it's going to be $3,000 or $4,000 before you even get 1 cent of reimbursement. Everything else is out of your pocket. I do have to say prevention is covered under ACA with no copayment, which is pretty important. But anything else is an enormous cost for young folks. The next one. And the crazy thing about high deductible plans being a way to save money is the fact that the 20% sickest folks in our population cost about 78% of the healthcare dollar, which makes sense, right? Obviously, you're going to spend a lot more money on those folks. The question is, why have very high deductible programs on all the folks who are not really spending a huge amount of money, other than these folks are now needed to avoid care because of how much cost? And the question is, how many of them are going to avoid that visit to primary care and are going to end up hospitalized and being high-cost folks as well? So it's a little bit of the crazy thing of these high deductible plans. And the next one. Overheads for insurance. A lot of PNHP's, Physicians for National Health Programs, ideas is that right now, with all these different systems, we spend 25% on administration of the healthcare system in the U.S. Some estimates even up to 30%. All the countries that have single payer systems spend about 10% on administrative costs. And the key thought is, why spend so much money on all the billers in the hospitals and doctors' offices and all the folks at the insurance companies who are looking to deny care, and then they have to hire more folks to get the bill approved, and then they have to hire more folks to deny the bill and cycle round and round. And it's like, why don't we just take care of patients rather than worry about the billing? Why don't we cut the hospital administration costs so hospital administrators can run hospitals and not try to create billing finance plans and business plans, et cetera. The next slide. And we see a massive growth in administrators. Every doctor loves this slide. The no line at the bottom is the growth of doctors over the last 40 years, and the other number is the growth of administrators in the system. And here we see currently of a dollar spent on medical care, about 10% goes to insurance costs and profits. About 10% is the insurance billers, meaning the folks working for the insurance company basically denying costs. Hospitals have to hire a lot of folks to get paid. Doctors also have to hire a lot of folks to get paid. This is the actual administration that is the important stuff that hospitals do, as far as hiring good quality personnel, making sure departments work well and on quality. So this is the important part of administrative costs. The rest of it is just this sort of wasteful billing, as it were. The next slide. I should say Medicare runs at 2% overhead compared to all this. So Medicare is a very efficient system. If you can go, well, also just the last slide is just the point that obviously when people aren't insured, the death rate goes up. There's sort of good statistics on that. And we see states like New York, who do a better job of insuring more of the populations, do have relatively lower death rates that are unnecessary due to lack of insurance, but still are too high compared to if we have universal health care. And as I say, so high deductibles, the idea with high deductibles, people will use less health care, and the answer is people do use less health care. They go to the emergency room less often, which is sometimes say, yes, not everyone with a cold should go to the emergency room. They also go to the doctor's office less often. They also get preventive services less often. As I say, yes, if it's more expensive to go to the doctor, most people haven't been to medical school, so they don't really know when they should or shouldn't go to the doctor, so they go to the doctor to find out. The next one here. And we do know many times when high deductible plans are put in place, we have a decrease in office visits and an increase in the number of days in the hospital that folks have. And the next one here. Sorry I'm going so fast through all these things. I just don't want to spend too long on this. Then the next slide. Thank you. So again, people both set aside care that they don't really need, go into the emergency room for a cold, but they also set aside care that's been proven to save lives. Cholesterol statin drugs cut down the number of heart rates. Blood pressure drugs cut down strokes. When people have high deductible plans, they take fewer of these drugs that have good evidence behind them. They also take fewer drugs that maybe don't have such good evidence, which is fine, but they take fewer drugs that lead to excess deaths, excess preventable deaths. The next slide. Breast cancer, one of the big breakthroughs really in medicine has been that the hormone blockers, tamoxifen, Femara, Aramidex, cut down dramatically the recurrence of breast cancer in women, and we see in high deductible plans that when co-pays are more than $30 a month, 30% fewer people take those drugs regularly. Again, a little scary for a doctor says this is a drug that makes a difference for somebody surviving their cancer or not, and to see 30% fewer take it with a high deductible. As Derickson had pointed out, prescription drug increases is a huge part of it, and we see that going. Every country in the world controls prescription drugs by setting the prices. The VA controls prescription drug costs by setting the prices. In the Medicare bill that passed in 2003, the Medicare drug bill, part of the bill, which was apparently written by pharma lobbyists in the back room with the Congress folks, said Medicare cannot negotiate for the cost of drug bills. And so this is a lot of the issue of just this massive increase. The next slide. We see in these other countries the same drugs are less than half the cost here. And the next slide. This slide is really appropriate for anything other than people remember the big problem of signing up for Obamacare and the big problem with the website, and that was largely fixed within a year, but it's still a very complicated system. What's your income? What category do you fit in to get health care? And this compares to when Medicare was passed in 1965. This is the very first person to get Medicare. Anyone recognize the signature? Harry Truman. So Lyndon Johnson made Harry Truman the very first recipient of Medicare. Within 1 year, they had 19 million people signed up with the fancy computer software of 1965 compared to the problem now. So, and a lot of this because Medicare is a simple system. Are you 65? You have Medicare, you know. So that's the same idea with single payer. Are you a member of our society? You have this. So rather than these complicated signups. As somebody had said, you know, we already spend over half of our healthcare bill out of public spending. This is up to about $10,000 a year. This is about 7 years old. $10,000 per person per year is spent on healthcare. About $6,000 of that's from public dollars, from Medicare, Medicaid, the VA, from New York Health and Hospitals Corporation, from federal employees who get it. So already 60% of our healthcare bill is paid for dollars. When you think about what country is taxed the most for healthcare, well, it has to be one of those socialized medicine countries must be taxed the most. They actually are taxed less than the U.S. for healthcare. And for that, we get about a third of the population covered, and a lot of people left uncovered as well. So as someone said, well, this means we're already 60% of the way toward a universal health care plan because we already have that much out of public funds. And the next slide. So how does a single-payer health system work? Single-payer is best described as improved Medicare for all. And Medicare for all, as someone said, wouldn't it be the simplest legislation to just take the word over 65 out of the Medicare legislation, and then basically you just cover the population. The issue with Medicare, though, there are too many deductibles and costs in Medicare, and we know seniors still end up with a lot of out-of-pocket costs. They end up with a lot of costs for drugs. They end up with a lot of co-payments going to the doctor. They have a fairly big deductible if they're hospitalized, et cetera. So improve Medicare for all would get rid of a lot of these co-payments and deductibles because we know that these tend to not benefit very much. If you can go to the next slide. So how does it work? Next one. So basically, businesses would pay their premium, and their premium would be based not on $18,000 per employee, but would be kind of a graduated tax, as it were, graduated premium, whichever word is politically popular, but would replace the insurance premiums businesses current pay. The government would then take that and then would pay doctors and hospitals to care for patients, and everyone's covered. So that's sort of the complexity of single payer. If you go to the next slide. So this bill has been out there. Gary Pretlow, who's the assemblyman here, is one of the persons who helped to vote for it, and it passed, I think it was 86 to 52 or so in both 2015 and 2016. So this bill has passed the Assembly. Dick Gottfried and previously Senator Perkins, but now Senator Gustavo Rivera of the Gustavo Rivera of the Bronx are the sponsors of this. And as I said, the state Senate, there's 63 state senators, 26 are sponsors so far, and the goal is over the next year, 2 years with the next election to get senators in there who will support this bill and to get a governor in who will sign it. The next slide here. How does it work? Everybody would be covered, no barriers due to sex, income, wealth, employment, or health status, no regressive health premiums, no co-payments at the time of service, no deductibles, no co-pays. The next. So what's covered? Healthcare is covered. And the next slide. So also, as people may or may not know, Medicare seems to be a fairly quick payer, from what I understand from The Economist, that when hospitals send in a bill to Medicare, they get it paid back in a reasonable period of time. They send a bill to the health insurance, they're a little more likely to get denied and a bounce back and forth. I don't know if you find that to be accurate. The one thing government tends to do good is get a bill and send out a check. And that because they don't have a for-profit incentive to say, well, why don't we delay this for 6 months and maybe we'll get away with not paying some of those bills. So how it would be paid, and this proposal has a graduated tax averaging around $10,000 per person. I think it goes somewhere around 9%. So an employer would pay about a 7% adjustment on income. An employee would pay about 2% of their income. Let's see. And when you compare what is paid now in health insurance premiums, it turns out 98% of New Yorkers would end up paying less for in that graduated premium than they do in current insurance premiums. The next slide. How do the finances work, right? This sounds too good. Do the finances work here? This was the financial analysis, was that there would basically be $26 billion saving from administration of hospitals. I'm sorry, $20 million from less provider billing, $26 billion that's saved from the insurance company profits, because under the system you would not need the for-profit insurance companies. You would have control of costs by setting prices for drugs and setting prices for medical equipment, excuse me. Reduced fraud, because now you have sort of a standard system as far as looking, are there any providers who are kind of gaming the system or overbilling? And then what would that money be used for? So because we've already expanded coverage so much, it would be about $4 billion to cover the rest of the folks who are currently uninsured. Medicare and Medicaid, we'd want to have fee equity, so you would no longer have folks who have Medicaid, where if you're upstate, a doctor's visits maybe only pays $30, so no doctors take Medicaid upstate because it pays maybe 60% less of what Medicare pays and maybe 80% less of what private insurance pays. So you'd want to make it, so just to bring that equity so that every human being, when they go to the doctor, it's the same payment, that would be about $10 billion there. Also, increased utilization through no cost sharing. It is expected there be some increase in costs through the lack of deductibles and co-pays, but that's part of the economics of the bill. And also, many insurance clerks and many folks like who work in my office and do a lot of the billing wouldn't really be needed to do that, so they would need to have other job skills, possibly providing healthcare, be trained as nurses or other things, using the money to pay for healthcare rather than for billing and administration. And the next slide. So what do the polls say about this? This is May 2016. Would you favor replacing ACA with the federally funded healthcare program, providing insurance for all Americans? 58 to 37. And how about doctors? How would doctors feel about this? So 59% of doctors said, would you support a national health insurance program? Would you support a single-payer national health insurance program? We see it varies by specialty. In most single-payer countries, doctors' salaries are in the same ballpark. Obviously, doctors' offices currently have about 50% overhead, meaning if if $1,000 comes in, maybe $500 goes to run the office and $500 goes to doctor salaries. Most other countries, it's closer to 20 or 30% overhead, so you don't really need to pay as much to make salaries. But for high-income specialties in most other places, many times in the U.S., a high-income surgeon may make 4 or 5 times what a primary care doctor makes, and they usually make more like twice what a primary care doctor makes in the U.S. So some of the high-income specialties is less favorability, but we see most other specialties favorability amongst doctors. And again, I think this is because most physicians just don't want to treat patients like you're an Aetna patient, you're a Medicaid patient, you're an uninsured, you're a patient, and this is what you need. So PNHP then plans, and we've been doing this for a couple years, going up with a couple dozen physicians and residents at my institution, and certainly members of the public as well are welcome to go up to Albany on April 4th to encourage, especially our state senators. My state senator, Jeffrey Klein, the head of the IDC, is not a sponsor of it, although I believe 5 of the members of the IDC are, and we're trying to get more senators to support that. So I think that's my last slide, so thank you very much for that. Oh, did you want to take it?
Thank you, Dan. The question actually I have is for Mr. Dahill. What's the position of your associations on single payer for New York State?
We have not taken a position in support. We have also not taken a position in opposition because the politics are what they are in New York. First of all, we believe this can only work if it was a national plan. It would be very difficult for New York as a state to try to put this in place because we have so many people that are on Medicare already, and how that would transition and work, it would logistically, I think, would be a problem. It all has a great deal of merit. I will say that my members, and this is not unanimous, but the majority of my members, because they've been interacting and transacting healthcare with the government for so many years, they don't trust the government. And it would only be satisfactory if there were real safeguards and firewalls in place so that we could rely on the fact that they wouldn't be cutting and coming in. So Medicare, it's absolutely accurate that Medicare pays quicker than any commercial insurance carrier, even pays quicker than Medicaid, pays closer to costs, doesn't pay costs, but pays much closer to costs than Medicaid does. But here's an example. Beginning 2 years ago, Congress authorized CMS, Medicare, to go out and hire bounty hunters. These bounty hunters came in and did retrospective audits going back 8 years and determined and pulled all the claims and determined that about 20% of inpatient stays should have been observation cases and took that money back from the hospitals. So that's an example of a problem that we see with government having full control. Now, if there could be protections and safeguards, we'd be pretty interested in coming around on it. And if the political picture changed, I describe Medicare as 1965. Lyndon Johnson puts it in place, and it was a promise made to all of us that all you had to do as a citizen is achieve the age of 65, and you were going to have your health care covered. But when they made that promise, we were supposed to be dead by the time we were 73. And because of all the other things I put up there, the technology advances and everything, we're not keeping up our end of the bargain. Right? And so Medicare is like it's not unlike a pension plan. That system will only continue to work if it continuously gets funded. And so that's where we get a little nervous about whether the government, like they've done with pension plans, shortfalls the investments, and then we get to a point where we got a crisis on our hands. So, but we're not opposing it because it has so much. We love to beat up the insurance companies, and the costs they've laid on us, and the cumbersome processes they've put in place have added, I think it's more than 25% in administrative costs now, because we have to have billers in the hospitals for Aetna. who know the Aetna procedures and know the Oxford procedures. I mean, it's incredible. So it has a great deal of merit. We're just worried about throwing all of our, future into the hands of the government. It might sound unpatriotic, but I'm sorry.
And I'll just put one. I mean, there's obviously very complex issues there, and I think that's a reasonable statement. One thing that I think always favors it, also favors Social Security and Medicare, is that everyone's in it. The most powerful and richest people in society all have Medicare and Social Security, and we see that those plans have generally been cut less than most other government plans. So this plan would be a plan that Bill Gates and Andrew Cuomo and whatever, the president's name really, but everyone would really have the same health care plan. That's one of the many protections. We hopefully hope democracy would protect it as well. And to a large extent, there is a bit of political contention in single-payer systems where the hospitals go to the newspapers and say, this is terrible, the government isn't giving enough. And then the government says, well, they're really looking for more than, and it sort of plays out contentiously. And that's a different way to kind of determine what's the right cost sort of in the public arena, as opposed to, for-profit companies just looking to play games to avoid costs.
And it's a major way of, that's a sort of nice way of saying capitalism is what gets in the way of a single-payer system. There are so many people who make so much money, millions of dollars off of commercial insurance, and to have the government take that away would take away almost what our society thrives on, which is capitalism. Companies, Oxford, Aetna, United Healthcare, et cetera, make millions of dollars in the healthcare industry. And to take that away from them who knows what that would do to our economy or to our market. So it sounds good, and it would be lovely if it would happen, but the reality is that this is a capitalistic society, and it's difficult to get around that.
They do it for half the price.
But they're not capitalistic societies either.
Let me just say that this is a very good point. I don't know if this is on. This is a very good point that there would be very powerful forces who make a lot of money that are against it. I just do want to say that when you think of the term like, is this a socialized healthcare system? And I say, well, socialized healthcare system is a term we use for how capitalist countries run healthcare systems except the U.S. So if you think of any capitalist country in the world, pick your capitalist country. I don't know. Is France capitalist? Is UK? Is Canada capitalist? Is Japan capitalist? Is Korea capitalist? Is Taiwan capitalist? These are all the capitalist countries in the world, and they basically all have this system. So anyway, that's how I feel. Socialized medicine is the term for how capitalist systems, except the U.S., run things. But it's not a small point. It would be an enormous lift.
As we bump up to the closing hour of 9 o'clock, I want to try to come back to an issue that was raised earlier on prescription drug prices. I think we all recognize that both the ACA, as it stood, over the last 8 years, did not address it adequately, and the new bill certainly doesn't address it. So the question that I have here is this. You indicated that Medicare or Medicaid today doesn't allow for negotiating those. Considering that we are going in the direction of more powers to the states, I want to propose the following. Number one, do panel members agree that this is a particular issue that requires further study and effort, lowering prescription drug prices? Let me just hear from each one of you very quickly. And would you be open to participating or continuing this discussion as a working group to look at ways to lower prescription drug prices in New York State in methods that are not being considered now? And the reason I'm saying this is when I look at some of the bills that are proposed today to do so, and I look at what Governor Cuomo has proposed recently, much of that focuses on setting prices or looking at ways to impose penalties if you go over those prices. And I have seen very little that looks at means that takes it down through competition, as the gentleman raised earlier. Whether it's competition or whether it's importing it from other places or other ways to actually take it down through capitalistic means you just raised. So these are things that are not being considered now. And I'm wondering whether panel members would be interested in pursuing a dialogue on that beyond this convention. Please answer that.
If I could just make the comment, I think some of that works for especially generic drugs, and this is where we see, whether it's the Target $4 formulary or Walmart or CVS or Medicaid, for generic drugs. This is where I've seen the market be very successful, where you can get lots of drugs for $10 for 9 months. For brand name drugs where there's no competition allowed, this has been the issue where there's no competition. So I think the thing is where there are drugs where there are more than 3 manufacturers of a drug, it does seem like that is an element where competition works. The big problem is all those drugs that are brand names that are the drug company sets the price and you either pay it or not. The sort of opposite of how other countries do it, where the government negotiates with the company and they set the price.
And you would need some sort of government regulation there, because these companies, the pharmaceutical companies, they make the product, they have a patent on it for X amount of years, and they can sell it at the price that they set on it because nobody else can make it but them. Now, once the patent goes away, in my business, we see that with oral contraceptives. They put out a product and no other company can make it for X amount of time, and then all of a sudden, when that patent expires, now the price drops down dramatically because now it's generic. So unless you have some sort of government regulation over the companies that make these products, you're going to have this disparity in cost. Blood pressure medications, one, new products on the market can cost you I don't know, $25 for a month's worth of pills. A similar drug doesn't work exactly the same, but in the same grouping will cost you $5 a month. But that's the nature of newer medications coming on the market made exclusively by one company and who has a patent on it. I mean, there needs to be some regulation there.
I think you raised a really great point that we need new policy solutions, because everything that's been put forth at this point for the past decades haven't been successful for a variety of reasons. But I also don't want us to lose sight of the fact that there are a lot of single-source generics that are increasing rapidly. We're seeing 800% year-over-year increases for generic drugs, but there's only one manufacturer. So competition in the generic market is also incredibly important as well.
Very good point.
I think it is an excellent point. I think that I've always been fascinated. You know, hospitals are buildings, and the physicians are really the ones that order the medications on behalf of the patients. So I think we'd have to get the medical societies involved in this as well, because I've always been fascinated with the front-end clinical trial regimens that go on.
Medical societies?
Yeah, the physician trade organizations. Because these drugs get incubated through a process that's unbelievably cumbersome and difficult. This whole clinical trial system, as they call it. And that's what allows the pharmaceutical companies throw a lot of money into that process, from what I can see. But they know they're going to benefit on the back end when they can justify taking this drug to market, because they either are a sole source provider or they've got a patent that is going to be a cash cow for a number of years. Yeah. Somehow in that front end, I think there needs to be a re-engineering that might be examined to go on. Because I think once you get a drug to market, it's almost, for a period of time, too late. So, you know, I'd commit to participating, offering whatever assistance I could bring, but I think we'd have to get the physician community really on board with at least just having an open and frank discussion about this.
Well, just
as a reference point, I guess for a senior care kind of organization, it is second to labor and food. It's the biggest cost, so it's a big deal. We don't really have the ability to influence it all that much, you know. To the doctor's point, I mean, talk about insurance, you know, power. The capital is the engine behind insurance companies. The pharmaceutical industry is just as powerful, you know. So they are real players in this. Yeah.
Well, I want to thank you for outlining our next steps in the forum, really pursuing opportunities that would find ways to reduce prescription drug prices. I want to open it up, the last question, because we are past 9 o'clock. Did we miss anybody's question that, you know, before we close here?
I wanted to ask about the generic and the brand. I personally, with a few things, especially with the diabetic brand and the generic.
You want to take the mic?
The medicine for diabetes, right, the ones for high blood pressure, the generics seem to have more side effects than the brand for the ones that I checked under. Okay, and I wonder why. Are they giving the generic more than more than they would give the brand? The brand costs so much more.
Guys, you want to take that?
In terms of side effects, I think most people associate side effects with how they feel initially after they take the medication, whether it's GI upset or something along those lines, nausea. Most of the generic medications probably don't have the same coating on them as do brand products. So you may feel a little bit differently on taking the medicine immediately, but if they're the same, if they break down to the same product in your circulation, they should have basically the same effect. You have products like angiotensin receptor blockers. I don't prescribe these, but I know these are antihypertensives. But there are new products on the market. A product, for instance, Edarbi is a new one. It's very similar to losartan, but if generic losartan probably might make you feel a little bit differently immediately, but ultimately, if you're taking your blood pressure over time, it's going to give you the same effect in terms of lowering your blood pressure. But probably what goes into making some of the brand products no longer has to go into the generic products, because now the patent is expired. Now they don't have to put all the same protective coatings that minimize gastrointestinal irritation on them. So you might feel a little bit differently in that regard. But ultimately, if it's the same active ingredient, you should get the same desired effect.
The insurance company don't even want to give you the they refuse to.
Well, because it's cheaper for them. Back to back to costs. It's cheaper for them.
Well, we've reached the end of our town hall. I want to take an opportunity to thank our panel members. Please give them a round of applause. Again, I would like to thank the Wartburg and Mr. David Gentner for allowing us to use this great facility. And I want to thank you, the audience, for being as open and receptive to all of what we did this evening. Thank you and good night.